Good morning, dear friends and colleagues. Thank you, Mr. Chairman. It's a great honor for me to be invited to 16th Turkish HPP Surgery Congress. It is my honor to be here because the Turkey is our brother country for Korea, and also Antalya is the most beautiful city in the world. So I have been here about 15 years ago, but when I come back to Antalya, it has changed a lot. So anyway, it is great to be here again. I have no conflict of interest. Actually, I'd like to appreciate Professor Mustafa Kerem and Bülent Aylundin for inviting me to this Congress. And Fatih also has been with us for about several months ago. We had a very good time in Korea. Thank you very much for visiting us. Also, thank you very much for inviting me this excellent Congress. Very good. As you know, lap liver surgery is evolving. So we think lap liver surgery, we think it is robot is included as lap liver surgery. Anyway, from open surgery, now minimal surgery is prevailing, but in the future, robot liver surgery may also be prevailing in the future. Today, about evidence-based lap liver surgery. First, I talk about obtaining evidence, and then because the randomized study is very difficult, I will speak about propensity score matching as evidence-based approach. Second. Then I will speak about robot assist resection. First, I talk about obtaining evidence in lap liver resection. As you know, lap liver surgery has many benefits, like a small incision, a scar, less pain, and less chance of wound infection, shorter hospital stay, fast recovery. But so many benefit, but still, if you look at laparoscopic cholecystectomy, there is no strong evidence like a randomized study laparoscopic cholecystectomy. But there's many benefit. That's why many surgeons and the patient favor lap liver resection. Before, this meeting is very important. In 2008, there's a first international consensus conference lap liver surgery in Kentucky, Louisville. I have a privilege to be a member of this international conference. If you see, this is Joe Buell is the host of this meeting, and Daniel Sheki and me and Professor Kaneko and many lap surgeon and open surgeon gather in this first conference. I think this is very important. Before this meeting, lap liver surgery was criticized so much because this is very dangerous operation. So you shouldn't do this operation like that. So, but after this operation, very important message was issued. This is the first laparoscopic surgery become standard practice. Although this is only a tumorectomy or lateral sectionectomy, anyway, lap surgery becoming first standard practice. Very important message from this conference. 2014, about 6 years later, there's a second international conference of lap liver resection. Actually, I also joined this conference. At this meeting, many lap liver surgeons has expected that the major liver resection can be standard practice, but actually it's not. In this conference, minor resection, lateral sectionectomy is okay, but still major liver resection is a still risky procedure associated with novelty. So major liver resection is very risky procedure, is still the message. I think major liver resection is still difficult operation for common surgeon. I don't know, someday major resection may become standard practice, but still it's not standard practice. there are few randomized study about laparoscopic surgery. One study is laparoscopic liver resection for colorectal liver metastasis. I think it's very important study in the history of laparoscopic surgery. This is also Cosmet randomized study. In this study, 280 patients were randomized, and 144 to open surgery, and 129 has been allocated to the lap surgery. If you see the conclusion, they try to do parenchyma sparing liver resection. Lap surgery was associated less complication compared to open surgery. Complication is less. Lap surgery is cost effective compared to open liver resection. Free resection margin is same, so they think this study support laparoscopic surgery in colorectal liver metastasis. After the reporting of this paper, this group has reported another paper in the future. This is recently 2 years ago, long-term oncologic outcome for this randomized study. In this outcome, same, 280 patients randomized, and 147 for open, 133 for lap surgery. If you look at the long-term outcome, overall and recurrence-free survival, there is no difference in overall survival between the laparoscopy and open surgery. And about the recurrence-free survival, there is no difference in the laparoscopy and open survival. But I'm sorry that there are still a few randomized studies after this operation. So in Korea, I think Turkish has a similar situation. So we have many cases of HCC patients, but there is no randomized study for HCC. About 2016, 7 years ago, we have reported about lap liver resection for hepatocellular carcinoma. It is 10-year experience for cirrhotic patient. In this study, we have 141 patients with liver cirrhosis and 91 patients and non-cirrhotic patient. If you look at the survival, you can see the green line is the cirrhotic patient, and blue line is the non-cirrhotic patient. Their disease-free survival is worse in cirrhotic patient, but overall survival is similar between the cirrhotic patient and non-cirrhotic patient. I think cirrhotic patient is contraindicated because of poor survival, but if you look at this overall survival, although disease-free survival is low, overall survival is similar between non-cirrhotic and cirrhotic patient. That's why we are encouraging this outcome. We decide to perform propenscore matching. As you know, propenscore matching is one statistical method to ensure confounding factor and bias equally distributed. So if you cannot do randomized study is maybe relatively simple in the medical treatment. But for surgery, randomized study is very difficult because the patient have to decide this surgery or another surgery. So I think propenscore matching is very useful for this evidence-based study. In this study, in 2015, we have compared laparoscopic versus open liver dissection for hepatocellular carcinoma. This is performed by propenscore matching. In this study, we have included all major liver dissection, and also we included all difficult lesions like segment 7 and segments 8 and segment 4A, 4B. So all the region is included. For disease-free survival, 5-year survival of disease-free survival, laparoscopy is 44%, open is 41%. There is no difference in disease-free survival. Overall survival, 5-year survival is 76% in laparoscopy and 73% open. So there is no difference. In this study, we found that there is no difference between the laparoscopy and open liver dissection. So I think PSM is a very good way to see evidence-based approach. So we, after that, we use many PSM for evidence-based approach. If minimally invasive surgery, there are many hurdles. So for example, large hepatocellular carcinoma, central lesion, multiple lesion is still controversial area for laparoscopic surgery. This is the consensus meeting, first consensus meeting, the content. About large tumor, because we tried to push the limit of lap surgery in 2015, about 8 years ago, we have reported on the large hepatocellular carcinoma. Is it still contraindication? In this study, this is the disease-free survival and the right side is overall survival. Median survival for laparoscopy for more than 5 centimeters is 33 months, 34 months. And also in the overall survival, median survival for large hepatocellular carcinoma is 61 months. I think this is good, result. So by encouraged result by good survival, recently we have performed the propensity matching for large hepatocellular carcinoma. This is laparoscopy versus open surgery. 70 cases in laparoscopy and 70 cases open surgery. In this study, we found that laparoscopy has a shorter hospital stay, similar blood loss, similar IJ resection rate. If you look at this before propensity matching, laparoscopy laparoscopy for large hepatocellular carcinoma is solid line. Open surgery for large hepatocellular carcinoma is dotted line. There is no difference. And also, this is overall survival. There is no difference between the laparoscopy and open surgery. This is after propensity matching. Laparoscopy is solid line, laparoscopy tissue-free survival, and overall survival. This is laparoscopy. There is no difference, although there is some tendency of better survival. Anyway, large hepatocellular carcinoma is still a controversial area, but after PSM, there is no difference between the laparoscopy and open surgery. How about multiple lesion? For multiple lesion, we need multiple dissection. This advantage of multiple dissection by laparoscopy is that increased operation time, increased bleeding. As a difficult in location, parenchyma saving is difficult, palpation is difficult in the multiple lesion. Anyway, this operation time and bleeding, increased bleeding is a problem of multiple dissection by laparoscopy. In 2012, about 11 years ago, we have analyzed data of our patient for multiple hepatocellular carcinoma. When we compared between multiple group and single group, operation time is similar between two groups and intraoperative transfusion is similar between two groups. Operation time and intraoperative transfusion is the most important factor in multiple lesion. But in our study about 11 years ago, there is no difference in multiple lesion and single lesion. Encouraged by this result, recently we have reported on laparoscopic versus open liver dissection for multiple hepatocellular carcinoma. The patient included within and beyond Milan criteria. Actually, this is the collaborative study between the Italian hospital and our hospital, because this is our international fellow, Dr. Gianluca Cassese from Italy, who has been with us for 1 year. So he reported on this. When you look at whole patient, overall survival is 5-year overall survival is 51%. Overall 51%, 49% in laparoscopy. Disease-free survival 26 and 17.8%, but there is no difference. How about beyond Milan criteria, there is no difference in the overall survival, disease-free survival. So even multiple hepatocellular carcinoma, this is debatable field, but anyway, in our collaborative study, there is no difference in overall survival, disease-free survival in between the open and laparoscopic surgery. In this study, we have concluded that liver resection for multiple hepatocellular carcinoma can be safe and effective in selected cases. Laparoscopy short to medium hospital stay without affecting perioperative and long-term oncologic outcome. How about aging? Previous speaker mentioned about aging and obesity. Aging is also a controversial area. Recently, we have analyzed our data between laparoscopy open surgery for elderly patients. There are about 900 HCC patients. Laparoscopy was performed for elderly patients in 127 patients, and in open surgery, 49 patients. We have propensity matching analysis. Left side are recurrence-free survival, and right side is overall survival. When you compare the before PSM, there is no difference. This is after propensity matching. There is no difference in disease-free survival and overall survival, although there is some tendency of better survival in laparoscopy. Anyway, still there are many hurdles in laparoscopy, and still there are dark gray area, but we can use PSM as evidence-based approach. How about robot-assisted laparoscopy? Robot-assisted liver resection, surgeon operate while sitting, so we may feel more comfortable. Even if we become elderly surgeon, we can do this robot surgery. So now robot surgery is becoming a hot issue. But still, in lap surgery, robot-assisted resection is still minority. Most of the surgeon is doing lap liver surgery for liver resection. About 2 years ago, we have reported our initial experience of robot hepatectomy in high-volume laparoscopic center. In our center, we are doing many lap surgery, but robot surgery is just starting now. Anyway, this is our report. So left hemihepatectomy by robot surgery. This is the cut surface, and we use ICG fluorescence for this left hemihepatectomy. Anyway, recently the Brian Go from Singapore has gathered so many patients from multinational center. So they have reported many good papers. I was one of this group for this robot versus laparoscopic surgery. There are many, but if, for example, robot versus laparoscopy for partial liver resection for enteroarterial center, their conclusion is this international multi-center study showed that robot and laparoscopy has equivalent outcome. But robot approach was associated with significantly lower blood loss, and there's a conversion rate is low. So there are similar study from the same group, Singapore group. This is a multi-center study. So many surgeons has contributed their data to this study. Many studies show that robot has a lower blood loss and lower conversion rate. Anyway, this is one study. Actually, this is reported from our my international fellow, Dr. Silva from India. So this is a limited resection for posterior superior segment versus laparoscopy versus robot-assisted surgery. Actually, the limited resection for posterior superior segment, segment 7, segment 8, segment 4A. In this report, we have concluded that robot surgery has reduced blood loss, low rate of conversion. So, same, many recent international collaborative big data show that robot dissection has reduced blood loss. We don't know. This is by robot itself who are learning, because learning curve, because many robot surgeons started from laparoscopy, they have many experience of laparoscopy, then they move to robot. That may have influenced the outcome. Anyway, still the results show the reduced blood loss, lower conversion rate. Anyway, there are so many data, similar data. This is systemic review and meta-analysis for the score. So anyway, many studies show that the robot is equivalent as laparoscopy. So, Dr. Aldirghetti from Italy, they have proposed the LAMO study. This is the laparoscope versus robot. Major hepatectomy, for major hepatectomy, randomized study. So this will start. So anyway, we will know that really, this is, previous international study is retrospective study. This is a randomized study, prospective study. So this will start. So if this study may answer which is better, robot or laparoscopy for difficult operation, major operation. Anyway, for young surgeon, robot surgery has a short learning curve. It's good time to start robot surgery for young surgeon. Everything changes. Nothing remains without change. Anyway, I'd like to introduce our conference, IALS 2025. This is the 5th World Congress of IALS. Will be held in 2025 in June 24 to 27 in Korea. So the venue is COEX. So I welcome all of you to this IALS 2025. Thank you very much.